Hi, I'm Dr. Jason Siefferman. I'm a physiatrist, interventional pain management doctor practicing in New York City. Thank you for having me. It's a pleasure to be able to join you today. And I chose the topic of pelvic pain because it is one of the more complex pain areas in the body. And it is a good place to start when talking about the complexities of pain and how we approach the diagnosis of pain. Back pain's too simple, of course. I'm kidding. Uh, so I have no disclosures. We're going to be identifying the steps of the diagnostic process. We're going to identify categories of treatments and go over treatment options. And we're going to reflect the process, the journey. We call it the chronic pain journey of diagnosis, treatment, and maintenance. So when we start, before we can do anything, we have to figure out what is going wrong with the patient. We have to consider all possible sources of pain. So as we are hearing the history, I'm thinking to myself, what does this sound like? What sounds like a primary issue and what sounds like it may be a secondary issue? And we'll sort of talk through what I mean by this. In general, a primary issue, we think of an actual problem, an anatomic problem, or a visceral problem. It could be something like endometriosis or hernias, or it could be a lumbar disc herniation. The primary issue doesn't always need to cause pain. It can be something like a hypermobile pelvic ring, where the instability of the pelvic ring actually triggers a guarding response, which downstream triggers other pains. The secondary is a secondary pain from the primary, and often patients will present with the secondary pain. They don't come in telling me what the main issue is that caused all their problems. They may think they know. And the story is really helpful for my understanding because, as you know, as clinicians, we've come to recognize constellations of symptoms. We understand how things come together and how, typical conditions evolve. So I'm considering all of these, but the secondary things are often what bring them in, and that might be the muscle pain. If we go out of the pelvis to the low back, a lot of people with low back pain come in with stiffness, tightness. That's really the muscle guarding that they're complaining about. They're complaining about the soreness there. They're not necessarily complaining about the anterolisthesis that's causing the muscle guarding. So same thing in the pelvis. If the hip is a problem, the sacroiliac joint will accommodate the hip to protect the hip. And so the hip may not declare itself as a pain generator, but the sacroiliac joint may declare itself as a pain generator. Or with the hip, they may be overusing the piriformis to keep the hip in an externally rotated state so that it doesn't impinge. That may present with piriformis syndrome. Or they may not even present with piriformis pain. They may present with sciatica, but the sciatica is from a piriformis syndrome, which is from the hip. So we're thinking about all of these layers in the biomechanical chain that can be causing pain, and each one can have its own set of trickle-down effects. The other thing I'm considering is, are they sensitized? And by sensitization, I mean, is their pain processing upregulated? Is their brain perceiving the pain as more intense than it really should be? And I subdivide this into three categories. I think of neurological sensitization, which we see with complex regional pain syndrome, small fiber neuropathy, migraine, central stroke, things like that. If they're neurologically sensitized, of course, the brain is not processing anything correctly, and they're just feeling lots of pain from light touch. Hot, cold might be uncomfortable. And we sort of want to identify that if it's happening. The next category of sensitization, I think of inflammatory sensitization. And this is very much Dr. Nino's domain, where if there's an autoimmune process or if there's some inflammatory dysregulation, it could be a post-viral, it could be chronic Lyme, post-COVID, or mast cell activation syndrome. There will be a sensitization of the immune system where the immune system is hyperreactive. And of course, that hyperactive immune system spills out lots of histamine, bradykinin, CGRP, all these other inflammatory mediators, which of course go to the nerves and get them excited. So if there's an inflammatory process in play, I want to be aware of that and identify that, because that also affects my ability to treat the patient. And then finally, this is what gets most patients with pain dismissed. It's the psychological sensitization. I'm sure you've all seen patients who have been to the ER 100 times for pain, and they're always dismissed. No one ever can figure out what's wrong with them. They tell them it's in their head, or they just have to live with it. And no one really takes them seriously. And if you can imagine a situation where something's real, it's terribly uncomfortable, it's affecting your life in multiple domains, and no one will take you seriously, it's hard to, as a human, not exaggerate, to try to emphasize the importance of what's happening to you. And that psychological sensitization absolutely amplifies their pain experience. It's generally not a conscious process, but it is a process that keeps their sympathetic nervous system hyperactive. It really functions like PTSD, where there's an exaggerated emotional response to the pain experience. They may have decreased tolerance for everything else in their life because the pain is overwhelming. And I use the analogy of the emotional bladder. If you can imagine a bladder that holds all your emotions, if you're 90% full all the time from the pain, the slightest little annoyance or inconvenience is just going to be too much, and you can't process it, and it spills over. So this is something it's important to recognize, because it must be acknowledged by you, the provider, and the patient in order to understand that it is happening and begin down a treatment path that will help them process it. And being aware of it is the first step. So I went through a lot of this initially identifying the sources of pain. So the history tells us a lot. How did it begin? How has it evolved? What have they tried? What worked? What didn't work? What made them worse? We learn from everything. And patients are often disappointed when something doesn't work, when something flares them, understandably. But the overarching story is those are data points, and diagnosis is an iterative process. Each data point we fold back into our working hypothesis of what's going wrong, and we use that to take the next step. So history is very important. Physical exam is often underappreciated, and I feel like it's a lost skill for a lot of practitioners in the US, but it's absolutely essential. This is where the physician and the patient, through physical touch, can actually reproduce the pain and agree what it is that we're going after. So when I examine a patient, I can often find many pains. Most of us walking around have some source of pain, whether we know it or not. It may not be bothering us, it may not be declaring itself, but I bet I can find a few. And is it an important pain or not? We have to figure that out. So the physical exam is really what it establishes rapport between the physician and the patient, because they know that you know, and it's very reassuring for people who have been dismissed a lot, right? So having that physical connection is important. The second thing about the physical exam is understanding the biomechanical chain of events. So what I was saying before about primary pains and secondary pains, they may not realize that their hip has some pain because they've been protecting their hip. So because they protect their hip doesn't hurt, they don't feel their hip, but it doesn't mean the hip is okay. It doesn't mean the hip is normal. On the physical exam, I can really get a good sense of whether or not the hip is a problem. And if it is, that's going to factor into my thinking. And even all those other pains that they weren't aware of that I pick up, those factor into my thinking, because again, I'm acknowledging a constellation of symptoms. I'm looking for a cluster of symptoms that fits with other diagnoses that have stereotyped patterns. So once we have a good sense of what's going on with the patient's body from the physical examination, that's when we will look at imaging and lab studies. And of course, most imaging is static, meaning it's not catching the patient in motion. Of course, we can do dynamic imaging, and I almost always do. If I'm imaging the neck, I will look for flexion and extension. I'll even get odontoid views with side bending, with the lumbar spine, flexion, extension. And we're talking about the pelvis. I'll often do a stork stand or a flamingo pose. I don't know what it's called in Georgia, but we'll have them basically put a leg up and look at the pelvis tilted to see if there's any shear at the pubic symphysis or any asymmetry at the sacroiliac joints. Of course, we'll also use MRIs and CTs. Those are static imaging. The patient is laying down. If their pain is worse while they're sitting, it's not always helpful to see them laying down, but usually we can get a clue. And whenever I'm teaching the fellows, I reinforce the importance of looking at the imaging and knowing how to understand the imaging yourself as a clinician, because the radiologist isn't seeing the patient, they're just seeing the study. And they're in a position where if they overcall a disc herniation, that patient might get a surgery they don't need. And of course, their main concern is not missing cancer. So as the clinician who's treating that patient, who knows the history, who knows what we may be looking for, it's absolutely important to see the pictures. The other thing I'll say is, a picture is worth 1,000 words, and an MRI is often 600 pictures, and an MRI report is never that many words. Moving on to the labs, this is where, especially with Dr. Nino's help, we'll look for an inflammatory process, or even with a lot of neurologic processes, if there's B12 deficiency, if there's B6 toxicity, if there's a chronic Lyme or chronic Epstein-Barr, any autoimmune inflammatory processes, the labs are really great for screening for those things. And of course, they're not common, but they happen. You would think in the United States, you may not see that much B12 deficiency, but it's extraordinarily common. B12 deficiency is so common that the lab value for normal is around 200 something, like 219. It depends on the lab. But that's just because the prevalence of B12 deficiency is so broad that the lab's 2 standard deviations considers it normal. And it's the same with testosterone. So again, looking at the lab, screening for these things, really knowing as a clinician what normal should be, regardless of what the lab tells you it is, just like with the radiology report. And then finally, once we have a working hypothesis of what we think is causing the pain, how it came to be, why it's happening, and again, let me say that again, because that's the important part. The diagnosis isn't just what the pain is, it's why the pain is, it's how it came to be, it's understanding the whole process that led to the pain generation. Because if we do not understand that completely, the treatment that we come up with is not going to be robust. It's not going to be durable. So we really have to understand the full chain of events mechanically that's occurring when it is mechanical pain. And it's not always mechanical pain. Like I said, sometimes there are hernias, but even with hernias, the hernias will often cause an anterior pelvic tilt, which will cause guarding, which will cause back pain, which will cause sacroiliac strain, which will cause tight hip flexors. And you see where I'm going with this. So once we identify what the primary is and treat that, we still often have to unwind the compensatory process that occurred because of that pain, right? So there's still work to do even after that primary is treated. So when we're looking at diagnostic testing, this is often injection-based because that's how we can selectively turn off pain from one structure to establish its role in the pain cascade. So if I do think it's a hernia causing pain, with the ultrasound, I can block the ilioinguinal nerve, I can block the genitofemoral nerve, I can go into the inguinal canal and I can flood it with local anesthetic. And if it is a hernia, that pain will go away. If it's not a hernia, if it's an L2 radiculitis that's going into the groin, if it's pelvic congestion syndrome, if it's a renal vein stenosis that's, dilating the gonadal vein, hopefully I'll see that on the ultrasound, but the local anesthetic in the inguinal canal does nothing for them. So it helps us be a little more precise with our understanding. And helps us understand what else is going on in the body. And of course, if there's a referral pain, that referral pain is going to persist. This we see a lot with pelvic pain because a lot of the viscera refers into the pelvis and even the low back, lumbar discs, transitional vertebra, Bertolotti syndrome, which isn't classically thought of as a pain generator, we see commonly as a pain generator referring into the pelvis. And again, they can be completely numb in the area where they tell you they have pain, but still have pain on top of that numbness. And that just tells us that it's a referred pain. Also, while I'm doing diagnostic injections, I might muddy the water a little bit, but with a clear understanding and a clear goal. Let me use sacroiliac joint pain as an example. If a patient has sacroiliac joint pain, or I think they have sacroiliac joint pain, and I'm not sure if it is inflammatory, like an inflammatory sacroiliitis, or if it's just hypermobility driven, I may do a local anesthetic injection with a steroid, but I'll use a steroid that doesn't work immediately. So when the joint is injected immediately, it will be numb. So if the sacroiliac joint itself is hurting, putting the numbing medicine in there will turn that pain off. Great, that's only going to last a few hours. That's the diagnostic test. Now, the steroid is going to take several days to start working. And if they have an inflammatory process, generally the steroid will help. So if they feel better while it's numb, great. It is the sacroiliac joint. Now, several days later, it often takes 2 weeks for the full effect of a steroid. If they're feeling better at 2 weeks, it's because the steroid had some effect. And then I can infer that there was an inflammatory process causing the sacroiliac joint pain, which actually takes me the next step towards treatment. I can kick them back to the rheumatologist and make sure that that's addressed. Any questions so far? All right, I'll keep going. And if you do have questions at the end, please, I'm happy to talk through any of this. When I'm thinking through these primary pain generators, I want to think about the reason for the pain. If there's an injury, of course, car accident, that's easy, right? A single distinct injury led to the problem. We don't think that that's going to happen again, but we do want to understand all of the mechanical effects from that injury so that all of them are treated together. A good example is a disc herniation in the back. That disc herniated, but often the supporting ligaments of the spine also sprained to allow for that disc herniation. And then there may be some other shearing, other effects. So it's screening for all of that. Degenerative changes, which of course we see frequently, osteoarthritis, the effects of gravity on our body, the effects of weight on our body, the effects of suboptimal biomechanics will all lead to degeneration. I think something that's often underdiagnosed is hypermobility. And this may be my bias. We see a lot of hypermobility or Ehlers-Danlos syndrome in our office. A lot of patients come in with pains and they don't realize that they're actually hypermobile, and it's the guarding of that instability that is leading to the pain. So identifying the hypermobility as the primary source, as the driver of the pain that brought them in is important, because if we don't treat it, it's not going to get any better. They'll continue to have pains. With pelvic pain specifically, hormonal imbalances, hormonal deficiencies directly affect the tissue integrity within the pelvis. And we'll see this with endometriosis. We'll see it with some birth control. We'll see it throughout the life cycle. And if that's something that needs to be addressed, that can make a tremendous difference by itself. Of course, autoimmune, mast cell activation syndrome, sorry. If there's any inflammatory process, we have to address that, and that's a systemic process. Endometriosis, adenomyosis, hernias, interstitial cystitis, any other visceral source of pain. And then, of course, there are primary neurologic sources such as small fiber neuropathy, neuroproliferative vestibulodynia. And then we see vascular issues. These are mostly venous compression disorders or venous congestion. So pelvic congestion syndrome, May-Thurner, I mentioned renal vein stenosis, also called nutcracker. I'm sorry, give me just a second. All right, let me go through a few examples of common biomechanical cascades that we see, just so you can see examples of what we're looking for. These are typical cascades, and you may have seen many of these yourself if you're looking for pain in the pelvis and diagnosing pelvic pain. So when there's any issue with the hip, it can be osteoarthritis, it can be hypermobility, it can be a labral tear, it can be impingement, maybe they have some hip dysplasia. Generally, these things can happen. There may be hip flexor guarding, psoas tension. That psoas tension can actually put tension on the lumbar plexus, because remember, the lumbar plexus and the genitofemoral nerve both run through the psoas muscle. So if that psoas muscle is chronically tight, you can have neural tension on those structures, and that can go to the groin or leg and mimic hernia pain. And I've seen this many times. And it's confusing also because they may also have a hernia. Many patients have asymptomatic hernias, and we just don't know if we don't look. Then once we look, if they have a hernia, sometimes they just automatically go for surgery because they have groin pain, they have a hernia. But it's important to do that diagnostic block, because that hernia may not actually be the source of pain. It may actually be psoas tension. And I've seen this in plenty of patients who had hernia surgeries, whose groin pain didn't get any better with the hernia surgery. And then I examine them, and it turns out it's their hip and there's psoas tension, and it's this pathway, but it feels exactly the same because it's the genitofemoral nerve being irritated. The hip will also lead to the obturator internus guarding, and the obturator internus will pull on the pudendal nerve, and that'll cause pudendal neuralgia. It can cause piriformis guarding, which can cause sciatica. It'll cause ilium rotation. So the sacroiliac joint will shift to guard and protect the hip joint, especially if the hip is unstable. By covering it more, it provides more stability, because the hip likes to anteriorly dislocate. That's why the hip flexor tightens, but also why the ilium shifts. When the sacrospinous ligament tightens, that can also put tension on the pudendal nerve, leading to pudendal neuralgia. And finally, even though I'm sure there are other options, we'll cap it at 5. The adductor longus is a common hip guarding muscle. It will often be substituted as a hip flexor, especially if the hip's in a little bit of external rotation. And it inserts at the pubic symphysis. Now, when there's chronic strain of the adductor at the pubic symphysis insertion site, it can actually pull on the periosteum. There's something called the aponeurotic plate, where the rectus abdominis, the inguinal ligament, and the ilioinguinal ligament and the adductor longus all insert at that fibrocartilage. And if it starts to pull on the periosteum is easily sensitized. If you're familiar with shin splints or medial tibial stress syndrome or Osgood-Schlatter, like there's a lot of situations where the periosteum gets irritated, and that can be extraordinarily uncomfortable. It's very sensitizing because the periosteum has sympathetic innervation as well as somatic innervation. This is a situation where it will refer into the genitals sometimes, or it can actually cause decreased sensation of the genitals. Whenever I have a patient come in saying they don't have any pain, but they can't feel their genitals, they're concerned that their pudendal nerve is injured. But generally, pudendal nerve injury doesn't just turn off sensation. Usually there's a progression of pins and needles burning, itching, pain that then progresses to decreased sensitization. If it's just turned off, that's usually the nervous system activating the gate theory to just turn off sensation to a region. One of the more common triggers for that is pubic symphysis periosteal pain. And I'll examine them, and if I push on that spot and it's extraordinarily painful, they didn't realize they had pain at that spot. They don't understand the connection between the two, but then we do a local anesthetic block at the pubic symphysis, and suddenly their genital sensation returns. Then we've confirmed that cause and effect relationship, and we know what we need to treat. All right, I'm going to go through these quickly. I think you probably have the idea at this point, but just knowing that each of these things has a number of trickle-down effects that all can cause pain. And so when I'm seeing any of these downstream effects, I'm trying to reverse engineer that process. So putting it all together, we're looking for primary pains, we're looking for secondary pains, tertiary pains. We're looking for why is it happening? How did it come to happen? And once I have a working hypothesis for that, then I try to educate the patient on what I'm seeing. And my general approach is to share my logic with them. I tend to think out loud. I connect the dots out loud in front of them and explain what's possible and how it may be happening and why I think it's happening the way that it is happening. And then we talk about how do we prove it? And then once we prove it, how do we treat it? And sometimes those proving it and treating it things come together because it's really difficult to know for certain if we got the diagnosis correct until we actually treat it and the treatment works. So I explain that to them as well. So when we begin treatment, I'm looking for sensitization and treating sensitization first. Because if they are sensitized, it's really hard to know if the anatomic driver is real or just upregulated. And if we do a treatment and they're sensitized, they're more likely to flare. They're more likely to not appreciate that the treatment is working. So this is where I may find a pain generator. I may turn a pain generator off, but because their brain is sensitized, they don't fully appreciate that it is off. The other analogy I'll use, not really analogy, but if they have 3 different sources of pain and they're all causing 8 out of 10 pain, if I take one of those 8 out of 10 pains away, their brain still feels 8 out of 10 pain. And you may have experienced this with patients too. And this is part of the diagnostic challenge, especially with pelvic pain, because if there is more than one thing causing pain and we don't make all of them feel better, they're not necessarily going to appreciate the improvement, even though we may notice the difference on their physical exam. So testing for treating sensitization first, whether it's neurologic sensitization, inflammatory sensitization, or psychological sensitization. And then, of course, in treatment, this is when we're actually getting the confirmation of which parts are involved, how and why. And this is something I spoke about a little bit with the steroid example versus the local anesthetic. When there's hypermobility, I'll use regenerative medicine. So I may use dextrose prolotherapy to start, which will help tighten a hypermobile structure. So if I think a hypermobile hip is the source of the piriformis guarding, of course, diagnostic injection with the lidocaine, but I'll also include dextrose to treat the hypermobility. Because if the hip is hypermobile, that by itself is going to cause its own problems eventually, if it's not already. But also, if the hypermobility is the reason for the piriformis guarding, then I also want to go ahead and treat that. And then we will find out if it actually is or not based on their response. So it's a little bit of an iterative process. And I explain this to patients because otherwise they're going to feel like I'm guessing. They're going to feel like I'm experimenting on them. But I explain the process, and I also share that everyone's unique. Everyone is an individual, and I may see 10 patients with back pain who all follow a different course, and we don't know who's going to follow which course. So we do what makes the most sense for each patient as we go through it. I can go off on a tangent for just a moment and talk about research in pain medicine. Any of you who have looked at literature for any treatment in pain medicine, the research is awful. We're lucky to eclipse 50% for most things. And the challenge is really twofold. One, the patient population is so diverse. It's so heterogeneous. And going back to the low back pain example, even if we know they have a herniated disc, even if our patient cohort is isolated to L4-5 herniations, even those patients, Many are going to do fine without any treatment and get better on their own. Many of them won't even seek care. And of those who do seek care, some will respond to one approach of an epidural, but not another approach of an epidural. Some will be steroid responsive, some will be non-steroid responsive. And it kind of goes back to understanding how and why that disc came to be in the first place, because to treat the issue, you ultimately have to treat the reason for that disc herniating. A lot of the times patients get stuck in this cycle of every 3 months epidurals because no one actually treated the biomechanical stress causing the disc herniation. So sure, they get an epidural, it calms the disc down, but that disc is still undergoing stress, repetitive recurrent stress. It's going to re-herniate. So you understand, when we're looking at a single intervention that doesn't appreciate the root cause, you're not going to get durable, across the board, reliable effects from a single treatment. That's the first problem. The second problem is there's no placebo in pain medicine. We've studied placebo in pain medicine. Even doing a fluoroscopic procedure on a patient has a 50% placebo rate. Doing an epidural with just saline has a therapeutic effect because there is a wash away effect from the epidural. So we have no reliable placebo. So when we're looking to compare a therapeutic intervention to placebo, it's hard to appreciate a big difference. So anyway, thank you for that little tangent. But for those of you in other fields like internal medicine, where you have very strong studies, reliable studies for hypertension, kidney disease, diabetes, we unfortunately lack that. We're a little bit in the Wild West in pain medicine. So we have to go through this, very detailed diagnostic process and an iterative treatment phase to figure out what will work for each patient. All right, so when I think of treatments, I think of them in 4 categories or 4 buckets, I will explain to patients. Medications are rarely curative. They have some diagnostic value. They help us understand the mechanism in play, the neurotransmitters in play. I may use a course of an anti-inflammatory to see if there's an inflammatory process. They can help me understand more about their neurochemistry. Medications can also be a means to an end. So if a patient comes in severe pain, we don't want them to suffer while we're figuring out what's going on. I can reduce their pain with medication, right? And assuming I'm doing no harm, we don't use, opioids often. There are situations where it's appropriate, but we generally don't. But we will use a combination of other medications to try to modulate the pain signaling so they can be more comfortable while we treat the underlying issues. Physical modalities, physical therapy, chiropractics, acupuncture, neuromodulation like electrical stimulation, or even the magnetic stimulation. There's a lot of brain reprocessing being done with Neurostar, which is a company that does TMS, transcranial magnetic stimulation. There's a lot of physical modalities which are essential for correcting the biomechanics. So physical therapy absolutely helps identify some of these biomechanical patterns because patients will get better when they're treated, or they will flare when they're ignored. And both of those data points are very helpful. Also, when a patient has acclimated to a pain, when they've lived with a pain for many years, they've compensated for it. They've changed their gait. They guard, they protect, and that biomechanical compensation is going to transfer stress to other areas because it's not a biomechanically optimal way of using the body. So that has to be undone. So even if I identify the primary root cause and I treat the root cause, the patient doesn't automatically go back to moving normally. They have to go through the process of rehabilitation to recognize the compensatory patterns they developed and back them, to unwind them. And that's a whole process. And it's important for that process that both the physician and the physical therapist recognize the pattern that's occurred and recognize the order of that pattern so that it can be worked backwards. Injections, procedures, these are diagnostic, therapeutic. There's a whole range of things we will inject. There's regenerative medicine, where we're trying to heal structures, things like platelet-rich plasma, BMAC, bone marrow aspirate concentrate, mesenchymal stem cells, again, prolotherapy, which I do most commonly, and steroids, of course. Hyaluronic acid we'll use as a lubricant jelly or filler for a joint. There's neuromodulation, where we'll use spinal cord stimulators, peripheral nerve stimulators. There's nerve ablations, where we may use alcohol, we may use heat in radiofrequency ablation, or we may use cold in cryoablation to, kill a nerve and take the pain away that way. So we generally approach these in less invasive to more invasive, and what makes the most sense for that patient and our understanding of their pathology. Generally, if they're having facet joint pain, for example, the joints in the spine hurt, sure, I can do a radiofrequency ablation and take away all sensation of those joints, but is that treatment actually the best for the patient? Is it the most appropriate for the patient? Because when we do that and we take away sensation of the joint, they have no awareness of their biomechanics around that joint. And those joints were hurting for a reason. And if I take away their sensation, the stress that was causing that pain is going to go unguarded. They're going to continue stressing those joints even more, and the joints will degenerate even faster. So we use these tools cautiously and at the right time. Finally, pain psychology. So the patient generally hasn't gone through this chronic pain journey before. They're doing it for the first time. And so not only are they dealing with the pain, all the changes in their life, they may not be able to work, they may have financial constraints because they can't work, they may not be able to care for their family if they have children. All the normal functioning of life is affected by pain. So they may not have the full bandwidth to also separately research how to navigate the pain journey. A pain psychologist is their coach. A pain psychologist takes patients through this journey. They prepare them for what's next. They give them tools to continue living their life around the pain. Psychological tools for pain processing. If there's psychological sensitization, the pain psychologist is essential. Like, the patient has to learn to recognize those unconscious reflexes, very much like PTSD, where that pain signal is causing an emotional response that's an exaggerated response, which is maintaining that sympathetic hyperactivity, which actually keeps a lot of the pain more intense than it would be if they weren't emotionally overreacting. So understanding that that's happening and learning tools. So things like EMDR, self-hypnosis, tapping, cognitive behavioral therapy has a number of tools where patients can recognize and stop that emotional cascade response to pain. And it's essential. The other thing, for patients to really transition into the maintenance phase, they have to learn to self-manage. This begins with the physician educating them about, what's going on with the body, why it's happening, how it came to happen. But on the patient's end, they need to start thinking granularly about their pain. They have to think, what sensation is actually coming to their brain? What does that mean in their body? And what is the appropriate response for them to take? So throughout the treatment course, keeping a pain diary, knowing what medications had what effect on which pains, will give them a resource. So when they feel that sensation again, they can look back and say, oh, that sensation was this, and I did this for it, and that was helpful. So they have their own little encyclopedia for their body. So the pain psychologist will also help them organize this pain diary and pain tracking. So that really, above all else, gives them a sense of control. The lack of control is common. When the pain is overwhelming, they can't work, they can't do all of these things. Patients feel out of control, and they will often assert control in a way that inhibits their own healing, right? They can say no. They can avoid certain things. They can lock themselves into that pain where they've actually found some familiarity and safety and security. And if we go off on a tangent here again, imagine being overwhelmed by pain, seeing lots of doctors who either tell you it's in your head, there's nothing wrong with you, or here, try this and it doesn't work. Try this, it makes you worse. You've kind of been around the block trying a lot of things and you're not getting any answers. Sometimes it's psychologically easier just to accept that pain, define your life by that pain, and not risk making it worse. And at the same time, the hope for making it better is dangerous. So it's almost essential for patients to give up hope, because hope is an emotional roller coaster. And they've tried hope before, and hope has failed them miserably. And they're still left with the same pain. They're still uncomfortable. They still can't work. They still can't take care of their family. So sometimes it's easier to just cling on to that. And with that is anger, resentment, fear, uncertainty, and a lot of anger again. So there's almost an emotional safety blanket in that ball of emotions. But that also becomes a little bit of an abscess, because then it defines their life, and their life is limited by that. And when I meet patients in that state, it's really difficult to drain that abscess, because that abscess has a function. That abscess is serving them. When they have a pain flare, that abscess empowers them. Anger is tremendously empowering. Resentment, guilt. A lot of patients feel guilt, and it's a reinforcing guilt. Part of them knows that this is not how life should be, but they don't know what else they could do. And they're afraid to do anything else because they've done everything else before and it's all failed them. You know, anytime you hear a patient say, I've tried everything, know that there's a little bit of this going on inside of them. And that's not something that can just be brushed over. You're not going to gain their trust. You're not going to be able to take all of them with you on that healing journey right away. It really takes a lot of baby stepping for them to see if you are onto something or not. So deep down, they want to get better. They absolutely want to get better, but they're deeply afraid. And it's easier to accept the pain and live with the pain than to go through that emotional roller coaster again of trying and failing and flaring and being disappointed. Sorry, I know this is intense, but if nothing else, understand this about chronic pain. This is where a lot of patients are at when they're coming in seeking care. And of course, most providers aren't thinking this. They're thinking, oh, well, your hip has this, or your back has this, or whatever. Let's do this, right? This is why I prepared this approach, and I give this lecture, because when you meet a patient in that situation, if you don't first do the work to comprehensively understand where they are, how they came to be that way, and a good majority of what it is that's driving the pain, you will have difficulty finding success, and you will have difficulty getting their buy-in. And all of that is absolutely essential. And of course, the pain psychologist will help them recognize that they're doing this and help them process their feelings around this so that they can engage with you on the treatment journey. All right, I'm going to go through some of this a little more quickly because I think I already said a lot of it, but medications, we have distinct goals for medications. I'll often try medication trials for specific purposes. There's diagnostic value in certain medication trials. The physical modalities I spoke through, and of course, we need physical modalities like physical therapy for any mechanical issue long-term. Otherwise, it's not going to fully rehabilitate. Procedures, helpful for identifying the structures, understanding the biomechanical cascade, and knowing if we're actually correct about the diagnosis, or sometimes other things pop up during the treatment process that we weren't aware of that were actually driving it. So a good example, if we go back to the hip and sacroiliac joint pain, if the hip is actually the source of the problem, but the hip is not itself causing pain, and the sacroiliac joint is covering the hip to protect the hip, and that's why the hip's not causing pain, but the sacroiliac joint is then hurting because it's being overused to protect the hip. If I treat the sacroiliac joint and I stabilize the sacroiliac joint, it can no longer protect the hip. So the hip will actually declare itself as the source of pain. And then I'll know that the hip was actually the primary, that it wasn't the sacroiliac joint. And then I'll have to treat the hip. So, of course, for pelvic pain specifically, I spoke through all of these. There's a number of different injection tools, and of course, a lot of different locations we can inject. I can go through this very specifically. If you have any specific questions about pelvic pain, we can talk through it, but I really just used pelvic pain as an example body area that we could use to talk through this process of the pain journey, just because it is so complex. And everything with pain psychology that I just went into, lots of emotions around pain, lots of ways that it impacts a patient's life. All of these cause feelings, unconscious and conscious, that affect the patient's engagement with care and response to treatment. All right, the final phase is the maintenance phase. Now, the maintenance phase is defined by the patient knowing, understanding, at the same level that the physician does, what's wrong with their body, what happened, what went wrong, how did it happen, and what happened as a result. The patient will also understand what treatments worked, what treatments didn't work, and they'll know how to manage a flare. They'll know how to respond if a pain returns, because they'll know what worked for them before. You know, this is really where physician as educator is key, because this is what the patients need from us, not to keep coming to see us forever so that we have all the answers, but to empower them so that they can run their own life. And of course, in the maintenance phase, there will be ups and downs, but mostly ups. I tell patients life is like the stock market, right? There are ups and downs with pain, but the trend is up. So don't look at it on a day-to-day basis. Look at it on a week-by-week or a month-by-month basis, and look at the gains. Oh, sorry. The other thing I want to say about the maintenance phase is this is when a lot of patients will have to process all of the feelings that were suppressed during the prior phases. So when the patient is going through the diagnosis and treatment phases, they're on a mission. They're at war. They don't have time to process what they're feeling about things. They're focused. But once they realize that this is going to be over, that there's some light at the end of the tunnel, that's when they start to think, oh crap, what have I been through? What was all of this? What happened? Like, where did those 5 years go? There's a lot of anxiety around what if it comes back. Having trust in the durability of the relief that they found is difficult, because they don't want to let go of all of those fear and anger feelings, because they might need them again. It's a little daunting to believe that they're better, right? They almost don't want to accept that they're better. Because if they're not, they couldn't emotionally withstand that trauma after everything they've been through. So knowing this as a provider, I will often give patients a heads up. I'll be like, I think we figured things out. I think we know what we have to do. We just have to do it and we'll get you there. Know that as you recognize things improving, you're going to be caught off guard by some anxiety, by some fear. You're going to have to process what you've been through. And a lot of it is also their sense of self, their self-identity, because a lot of patients come to identify with the pain. They claim their diagnosis as their identity as they're going through this, because it's almost like a key that they think will unlock the answer for them, right? Especially, things like fibromyalgia. Patients cling to it. But once that's no longer defining them, they have to figure out who they are. And all the hopes and dreams that they had for their life that they had to throw away, now they have to reconsider what they're going to do with their life. Are they going to return to work? How are they going to find meaning in life? Because also for the past several years, hopefully months, their life was defined by this journey, by fighting the pain, and that's no longer necessary. So there's a psychological reckoning that occurs in the maintenance phase that is intense, and it catches patients off guard. So being aware of that, knowing that the patients will need some guidance through that is important, because it really is like the PTSD that a lot of soldiers get after returning from war, right? They almost feel more comfortable going back to war than staying home and building a life. It's very similar. So thank you for your attention. I know this is a very intense topic. It's a very complex topic, but it's also a very important topic, which is why I'm very happy to share with you. And if you have any questions, I'm happy to speak through them.
Thank you very much. Thank you. Thank you very much again, Dr. Siefferman. We would like to, if we because we have a few extra minutes, we would like to invite our audience if they have any topics of discussion. კითხვა თუ გაქვთ ან რაიმე დისკუსია თუ გაქვთ, ერთადერთი თხოვნა გვექნება, რომ აქ არის მეორე მიკროფონი, თუ შეიძლება რომ მიკროფონთან გამოგზავნდეთ და რომ უკეთესად ჩაიწეროს ხმა. რამე კითხვა ხომ არ გაქვთ ჩვენს სპიკერთან ამ თემასთან დაკავშირებით, if there are any questions. Sorry, we're translating back and forth.
No, of course.
Yeah. Before there's any questions from the audience, is it okay if I could ask a question, Dr. Jason?
Please.
Yes, regarding your topic, which is so important because it spans many organ systems as well as many diseases and conditions, could you speak briefly about the demographic of patients you see, for example, age groups, maybe genders, just to talk about which are the population of patients who maybe suffer from these kind of extreme pain conditions? Thank you.
Of course, anyone can have pain, and different pains declare themselves at different points throughout life. Our office sees a lot of patients with hypermobility spectrum disorders like Ehlers-Danlos syndrome. That's probably about 85% of the population. We also see a lot of headache and a lot of pelvic pain. And of course, with Dr. Nino, she sees all the autoimmune inflammatory conditions. So as you guys likely know, the autoimmune conditions generally declare themselves in the 20s or 30s, but some patients slip through and they don't declare themselves until later in life. Those are usually the more mild presentations. Hypermobility can declare itself at a very young age. I've seen 9-year-olds with pain from hypermobility. Generally, it's in the early 20s, sometimes later 20s or early 30s, but generally early 20s. And again, it's underdiagnosed. So I'll see a few patients in their 40s or 50s who have the long-term effects of hypermobility, but their hypermobility was never diagnosed. And because it wasn't diagnosed, they started accumulating all of these other pain syndromes, which just piled on. And then we have a lot to unravel. And of course, things, more typical things like lumbar disc herniations, cervical disc herniations, generally occurs in the 30s and 40s, sometimes in the 20s, but it's generally thought to be an older person's issue, but it's not. The discs are squishier and they're more easily herniated when we're younger. So 30s and 40s quite common. And then, of course, the spinal issues with age are more related to degenerative changes, osteoarthritis, spinal stenosis, things like that. And of course, osteoarthritis we see at later ages, just because it takes time to build up.
Thank you very much. Thank you. Is there maybe a question from the audience? Yes, Taka has a question. 1 second.
Thank you so much. Excellent presentation. I have a question, like many pain may be generated by multiple reasons. So I'm curious to expand a little bit. Do you prioritize the treatments or can you just treat the pain? So what is the steps that you may take if the pain is generated by more than one reason?
So it's really understanding everything that's causing pain and understanding the relationships between all of those things causing pain. And as the physician, I really have to have a holistic understanding of what's going on in the patient's body. So when there are multiple things causing pain, are they independent, separate things? Like someone can have endometriosis, they can have hernias, they can have hip impingement, and they can have migraines, right? And I want to treat all of these things. Generally, I'll start in the order that bothers the patient most. That's one priority. But also, I'm aware of the relationships between them. So if someone is having migraines, that's a form of neurological sensitization. And if someone is having chronic migraines, their brain's not happy. All of these other pains are going to be worse because the brain's not happy. So even if the migraine is not a priority for the patient, it's a priority for me. And then, of course, if there's an anatomic structural issue like a hernia, that hernia is going to affect how they use their body. That's going to have downstream effects biomechanically. So getting that corrected is a priority, and of course, hernias will cause chronic constipation. Chronic constipation is going to cause more pelvic pain. So these things layer on top of each other. So understanding the cascades that are typical for each condition, recognizing how broadly the patient is affected by each one, and then sort of lining those up to, put them in the most order so the patient gets the most relief the quickest.
Thank you very much. We have time for one more question. Oh, okay. If you have time, Dr. Jason, just...
No, I'm good.
Okay.
Hello, Dr. Jason. It's Aza here. Hello from Tbilisi. Thank you for a perfect presentation and very important topic you brought up. And thank you for psychological part of it, which you really feel like it's very, very important part of it. So I just wanted to share with you QEEG analysis in pain management and neuropsychotherapy effect. We recently had a patient with a migraine pain and in our center, Neuropsychomodulation Center, which is in Tbilisi now. And we had a QEEG analysis which showed intercingulate hyperactivation, which is exactly what you were talking about, which is causing hypersensitivity and pain is manageable when we try to train anterior cingulate with neurofeedback and TMS deactivation. So it was extremely helpful. And I have a question. It was kind of experimentation from our side. And I have a question. If you ever had an experience using TMS for management, pain management. Thank you.
Thank you. I wish I had more. In the US, unfortunately, the TMS is not FDA approved for pain. It's only approved for depression.
Yes.
So insurance only covers it for depression. That's the first challenge. The second challenge is, even though there are some pain treatments mapped out, they're not broadly studied and they're not broadly taught. So the first issue is access. A lot of patients don't have access because it is self-pay. And then the second issue is having a protocol that's proven for whatever's going on with that patient. And then the third issue, of course, it goes back to the cascade. And the TMS is tremendously helpful for the sensitization process. But if they're having a focal anatomic problem, it won't fix that. And we can reduce the sensitization, but if we don't fix the anatomic problem, that sensitization, it's a neuroplastic process. It will just come right back. This is a tremendously helpful tool, generally best used towards the end once the mechanical parts are better, but the brain hasn't reset itself.
Sure. Thank you.
Thank you very much. Thank you. Okay. Thank you so much, Dr. Jason. This was a wonderful lecture, wonderful discussion. Thank you very much. And we know that it's early over in the US, so
thank you for having me. It's my pleasure.
No, thank you very much. So have a great rest of your day. Thank you very much.
Thank you. You too.